Everyone, welcome. What an amazing day and what an amazing venue for a meeting. You know, usually these things are in some sort of church basement slash dungeon, but we're in this magnificent, if not slightly haunted hotel with these wonderful views of the mountains. So I moved here to the Carolinas at the beginning of 2023. And it's really an amazing place, both the people, the medical community, and the opportunities. So this meeting really flows from a partnership that we've developed amongst the MPN team for the Carolinas. Dr. Lindsay Rain from Duke, Brandy Reeves from UNC, Alex Koltoff from Medical University of South Carolina, and my colleagues, Dr. Rupali Balve and Michael Grunwald, who are with us at the Atrium Health Wake Forest Baptist Comprehensive Cancer Center, which is both in Winston-Salem and Charlotte. And we got together with a concept of partnering with my longstanding friend Naveen Pemaraju of moving what had been our Texas MPN workshop, a physician and scientist meeting, from Texas to the Carolinas. One, not nearly as hot, and two, a beautiful region of the country with many different interesting venues. So this will be likely an annual physician meeting. We'll work with Ann about the patient meetings to kind of coincide. Having them both together always works well because we're bringing in physicians for a larger meeting so we can really have a very robust faculty for the patient meeting. And we'll be, again, rotating around. There's much evolving in the MPN, so we hope that this is a helpful day. Here we go. Here are my disclosures. I've been involved with most of the therapies that have been developed in the MPNs. So to orient you a bit to the day, first this morning we're going to have, I'm going to set a little bit of the kind of framework in terms of MPNs, what they are, how we got to this point, so then we can also discuss where things are going. Dr. Grunwald will be talking about stem cell transplantation. Naveen Pemaraju from MD Anderson will be here a little bit later to talk about new therapies in development. Sadly, Dr. Michaels wasn't able to join us, but we'll be talking about clinical trials, and I'll be calling on my colleagues and fellow organizers as well to chime in for a bit more of a discussion than a lecture. Angela Fleischman, who's done a tremendous amount of work in the MPNs on a range of areas. We'll be focusing today on MPN, familial MPNs, a frequent question that we have. Then after lunch, Dr. Rain will be speaking a bit around gender differences that are very relevant and a bit of a lead into that Women in MPN conference that Ann had been mentioning. Dr. Koltoff will be talking about progression in MPNs. You know, why do they get worse? That's really a key topic in this field. Dr. Reeves will really be taking a deeper dive into trying to understanding where we have targets for our blood counts and why. Andrew Kuykendall will be taking a deeper dive in terms of the medicines that we use. We'll be hearing a bit from our colleagues in industry in terms of therapies and development. And then what's usually one of the more rewarding parts of these meetings are breakouts by disease, where you can ask kind of more in-depth questions as well as hear from each other. And then I think we have a bit of a mix and mingle with, again, some beautiful afternoon views. So the MPNs, how did we get here? So these are the myeloproliferative neoplasms. So again, like many medical terms, you quickly figure out that they are a fancy way of describing something relatively simply. Myelo means bone, proliferative means too many, and literally just means that these diseases were named because of overcreation of blood cells. Now, when we think about the blood is about half cells and half water. That water is plasma, it's got dissolved proteins, it has salts in it, and the issue we're talking about are all in the cells. All the cells are made in the bone marrow, particularly after we are born. And about 99% of those are red blood cells. And there's just a small fraction that are everything else. When we spin a tube of blood down, the rest of that literally looks like a little strip of white, are both the white blood cells and the platelets. And there's many different subtypes of white blood cells. All of the cells are important. They're all made in the bone marrow. They're like branches from the same tree. Indeed, if we use kind of a tree analogy, they're kind of like the leaves. Now, why the bone marrow runs into problem is the bone marrow is incredibly active. It makes billions of cells every day. And because of that, there are things that can go wrong as cells are turning over with genetics. And one of the key reasons we think that we develop blood diseases in general, and why blood diseases become more common as we get older, is because of how active the bone marrow is. So that the likelihood of something that has gone wrong not being identified and destroyed by the immune system, which is kind of the quality control of the blood creation, increases with age. Now, if we think back to how these diseases were found, we started by really trying to separate an increase in blood cells for one reason versus a bone marrow condition. So, for example, erythrocytosis is the medical term for too many red blood cells. And there are many reasons we can have too many red blood cells. We can live at very high altitude. So if I was to check the blood of people that live in Salt Lake City or Denver or in Tibet, their blood counts are going to be higher than people who live at sea level, and sometimes quite a bit more. Or the body is compensating. We know that people that have smoked or are smokers, the body makes more red blood cells to compensate. So when physicians see an increase in red blood cells, they're trying to separate. Is this a body responding to this, or is it solely something wrong in the bone marrow? In the US, sleep apnea, people who take androgens or testosterone as a supplement, all of those things can increase red blood cells. Platelets. We can have an increase in platelets from a bone marrow condition or secondary causes. People that are iron deficient, people that have infection or inflammation, people that sometimes have a hidden other cancer. Now, usually over time, it becomes clear most of these other causes become fairly apparent over time in helping to separate those causes. And even fibrosis. So myelofibrosis is a medical term that means scarring of the bone marrow. What is very confusing is that myelofibrosis both refers to scarring in the bone marrow, but it also refers to the disease of myelofibrosis. These two things are not the same, and this creates a lot of confusion, of which we have no ownership of, but to try to separate that. You can think that the condition of myelofibrosis usually has that scarring as part of the condition. There are other things that can lead to scarring in the bone marrow, and when we diagnose MPN, we are, on this slide, trying to separate all of these secondary causes from is it a bone marrow condition or is it one of these other causes. Now, these groups of disorders were aggregated or thought of as a family of disorders going back to the 1950s. There's a very famous hematologist, Dr. William Damashek, who described that these diseases were interrelated. He also had speculated that there were other diseases that were similar that were also part of this family. Over time, we have separated some of these to be considered with other diseases because of we understand more about their biology and those aspects. Now, with MPNs, how have we gotten to where we are now? In terms of therapy, I'll share kind of a couple of high-level pieces. And again, my hope this morning was a bit to give kind of the framework so that as you hear some about the new therapies, where research is going, you have some base to kind of build that house of knowledge upon. First, we know that it matters to decrease the risk of blood clots or bleeding in ET and PV. This is a real risk with the disease. And within ET and PV, our goal is to make the disease as invisible in your life as possible, which means protecting you against blood clots or bleeding, hopefully trying to reverse or control any symptoms that you have, and in the ideal world, helping to prevent progression. Now, with trying to decrease that risk, we've learned a few key things. One, controlling an increase in the red blood cells is important with control of the hematocrit. Two, aspirin is frequently helpful, particularly at low dose. And three, the use of medications to control the blood counts is helpful in a subset of individuals. Myelofibrosis is more complex. It affects people in more ways. It leads to enlargement of the spleen. It can lead to a decrease in the number of cells we need because the scarring interferes with the production of blood cells. And the symptoms can be sometimes more problematic. It can lead to unexpected weight loss, which in our society just does not happen. Sometimes we try to lose weight. We still don't lose weight. But people will lose weight from an illness, and they're still happy that they're losing weight. So fascinating on many levels. But when someone tells me, boy, I lost weight without trying, again, always a bit of a red flag. Other things, night sweats, bone pain that can really be different. Now, I mentioned aspirin because when we started with these diseases back in the 50s, they gave individuals 4 adult aspirin, so 4 times 325 milligrams, and they found that people had, not surprisingly, bleeding ulcers. And then decided, no one should get aspirin. And like many things in medicine, it is not only about choosing the right therapy, but how you use it. What is the dose? How do you individualize it for that individual? And over time, it was shown clearly that if we use just a baby aspirin, 81 milligrams, that can be very protective, barring an individual being allergic to aspirin or other things. At some point, we'll drop the term baby aspirin because, of course, we haven't given a child aspirin in like 40 years because of the risk of Rye syndrome. I don't know if you all remember, my mother would always chase me around with that bottle of St. Joseph's aspirin. They had that orange flavor. It was kind of chalky, a bit like the orange dreamsicles. Somehow we did not magically, none of us died from Rye syndrome. So I think that was a bit exaggerated, but anyway, we don't give it to the kids. Hydroxyurea. Now, if there is a maligned drug in an MPN meeting, it's hydroxyurea. And I think a lot of that, to be honest, is really quite unfair. It is a good medicine. It's a medicine for certain individuals is really a great fit. It's not a perfect medicine, and I think we all work toward having better and better medicines where we don't need hydroxyurea. But it controls the counts pretty well. Most people feel fairly well on it, and it's cheap. So all of those are really quite helpful, and globally is a heavily utilized medicine. And in each disease, we'll talk a little bit about them, but it clearly has its role. And I'd say its role is strongest in ET in terms of the data that we have. It clearly has a role in PV, and its role is probably most complementary in myelofibrosis. I kind of use it like the analogy of cardamom. Any of you who bake, cardamom is great, but you could clearly overdo it. It's something you kind of sprinkle on top of the rolls. And I view it just like that, just in combination with something else. Anagrelide, also a very cinnamon-like sort of thing. You can do too much cinnamon, and a little bit of anagrelide goes a long way, usually in combination with other medicines to help to control elevation in the platelet counts. Too much anagrelide usually leads to side effects that are really quite limiting. And part of the reason we use hydroxyurea and anagrelide, but have still view hydroxyurea as the preferred therapy over anagrelide for control of platelets, were important studies that were done in the UK that showed that hydroxyurea was the better medicine. This somewhat opens the door to the talk I'll have later really around clinical trials. Clinical trials are where we really determine in the most objective way that we can what is the safety and benefit of a medicine. And this was a trial that they did 100% to show that anagrelide was better. And the trial showed that it was not. And that was a really important study to do. Now, one of the most powerful things I think we have found over time is that gathering folks like yourselves together along with physicians and experts and others is very powerful. Having an MPN is its own difficult journey. And again, having met many individuals, having met many of you and having met many of your other individuals that face these diseases over time, it's challenging to have a disease that is really not a common disease. People have a difficult time relating. Well, what is this disease? You know, if you describe it to a friend, do they think you're going to die tomorrow and they're acting all weird because, you know, oh my God, don't pick up that book, you're going to die if you exert yourself. Or the flip side, since you look fine, they assume that there's nothing wrong with you at all. And even if you feel terrible, it's completely ignored. So there's a real stress to having a rare disease. You know, if you tell someone you have a disease, diabetes, God forbid, breast cancer, colon cancer, people have a framework. They know someone who's had it, maybe they've had it, you know, their sibling, their spouse has had it, they immediately are able to relate. But when you have a disease that they have to kind of look up, or if you have a disease that they really refer to with an acronym, you know, whenever you have one of these initial diseases, and there are many of them where people have to kind of look up and Google it, you know, that is a limiter. So that's why things like the work that Anne has done and many others are really bringing patients together to be able to take a much deeper dive than you ever could in a 30-minute physician visit. You know, physicians, nurses, they all care very much to try to teach as much about the disease as they can. But it's tough. There's a lot to absorb in the doctor's office. You've got a lot kind of on your plate trying to understand kind of what the next step is. It's a tremendous amount to take in. So these meetings are important. And there was a patient back now really from the mid-90s, Joyce Niblack, who deserves a tremendous amount of credit. She ended up passing from myelofibrosis after many years. But she was really one of the first, long before these things really became commonplace, of gathering physicians and patients in the same room to talk in a casual fashion. Now, why do MPNs occur? So first, the core thing is we don't know why they start to begin with. People say, is it something I ate? Is it something I did? Probably not. Not as far as we could tell. There may be exceptions. There may be exposures, as Anne had said, perhaps rare things, people that have had radiation exposure or Agent Orange or others. But that's relatively rare, but probably real. The process of aging is probably most central to this issue. And that there's this pressure on our bone marrow over time to develop illness. Now, a true key moment in the history of understanding these diseases was the identification of the JAK2 mutation. JAK2 is, you could think, like a on-off switch for telling the blood cells to grow and divide. It's one of many, it's not on its own, and it's part of a pathway that we call the JAK-STAT pathway. You could think it's like a thermostat or a light switch, again, where the body is controlling things. And the body really cares about having things in a certain range. Too much or too little of almost anything in the body is bad. Sodium, calcium, fat, cholesterol, and most certainly the number of red blood cells, white blood cells, and platelets that you have. Too many or too few will cause harm to you on either level of that. So you can think that it makes more, that on switch is on, and it's making cells, and then it turns it off, and then it drops, and then it's on, and then it's off. And then it keeps you in that range through that process. When you have a mutation, it's like the on switch got flipped on, somebody put a piece of duct tape on the switch, and it's stuck in the on position. And so that drive to make too many cells is there 24/7, unless something limits it. What limits it? A medication, perhaps. If you're getting phlebotomies, what limits it is you become iron deficient through phlebotomies. You just don't have enough iron to make any more, and that keeps it in the normal range. Now, with the JAK2 mutation, we have learned over time that there are additional mutations, two in particular to call out, calreticulin and MPL, that can be present in ET or myelofibrosis. All three of these mutations still are working on different parts of that JAK-STAT pathway. So medicines that inhibit the JAK-STAT pathway are relevant across all three of those mutations. We've learned over time now dozens of additional mutations, some of which tell us more about how active the disease might be, how much it might progress, or other aspects in terms of the behavior of the disease. So there are times that your physicians will be ordering panels of genes that we frequently can check now from either blood or the bone marrow that look at 40, 50, 80, 100 genes. We estimate roughly that there's about 20,000 genes, but that there are, again, this subset that are relevant in terms of these disorders. Now, it is thought that these diseases have the potential to progress. And part of these issues of why they progress can include inflammation, can include the development of additional genetic changes, and can go from a phase of ET or PV, which we consider kind of the earlier base form of these diseases, to myelofibrosis. Sometimes people are diagnosed with myelofibrosis as their first disease. Sometimes they're diagnosed with that as having progressed from ET or PV in individuals that had an ET or PV, sometimes for 10, 20, 30 years, and it can progress. And then finally, it can progress to acute myeloid leukemia. Now, acute leukemia is very serious. Myelofibrosis is more serious or threatening than ET or PV. It can be life-threatening in and of itself. Acute leukemia most definitely is life-threatening. We really want to try to avoid the development of acute leukemia if we can. There's a lot of research going on to try to figure out, well, how do we do that? We do not have a perfect way to stop that from occurring. It only occurs in a subset, probably clearly less than 20%, and depending upon who you are, maybe even 10% of people progress to acute leukemia. But in acute leukemia, why that is more severe is that the blood counts are dramatically lower. The bone marrow and the ability of the bone marrow to function really ceases to function the way that it should. So the blood counts actually become very low. And the consequence of very low blood counts can be very life-threatening. So clearly, acute leukemia is the villain we hope to avoid. Now, how do we treat the diseases? Well, first, we really have to start by talking with you. We have to understand how the disease is affecting you. You know, I look around this room, and again, you're a very heterogeneous group. I think about the last 2 weeks, I've seen individuals that range from 88 to 16. Tremendous amount of variability in age, in gender, in every other aspect of your health. You are not an MPN, you're an individual who brings everything to the table, you know, when you face an illness like this. It's just part of who you are. And how the disease affects you, really, it depends a little bit on everything else that's kind of going on in your health as well. Also, biologically, they really can be quite variable. Some people have a lot of symptoms, some people don't. Some people have had risk of blood clots, others will never have a blood clot with one of these illnesses. Some people have low blood counts, some people have enlargement of the spleen. Some people are more prone to progression than others. So part of what we try to do is really figure out as best we can, how has the disease affected you already, and how do we really help to try to keep it as invisible in your life moving forward as possible. Now, we've learned over time that symptoms are a key factor in these diseases. Not everyone has them. They don't always get worse, but they can be very real. And the most common one is fatigue. And these symptoms have a link to the biology of the disease. They're not just random. And when we first started doing this research, people, it was amazing. Even medical reviewers of the research were very judgmental. They'd be like, well, these patients say they're fatigued. I'm fatigued. I'm taking my kids to soccer, and I got my daughter in this, and I got, I'm working busy. We're all fatigued. This is different. And many of you have told us it's different. This is not the fatigue of, I'm busy, or I put in a hard day's work, or I worked all day in the garden. This feels pathologic. It's like when you have the flu, and it feels like you just have like a lead blanket on you. It's different, and it's linked with biology. Likewise, each of the symptoms tells us something different about the disease. Inflammation, a clue, an event that has occurred from the disease in and of itself. We've learned more about different markers, proteins, and inflammation associated with these. Now, as we try to evolve as a field, we want to really try to evolve from the concept of, boy, you have ET, all of you should absolutely be on this medicine exactly the same way. And really evolve to where we really have a much better understanding of how do we really help you in the most complete way that we can. Both with medicines, but certainly well beyond medicines as well. Diet, exercise, activity, sleep, etc. You take anyone, and if they have a bad diet, they don't exercise, they don't sleep well, I don't care what medicine you're prescribing, you're not going to feel well. And it is amplified when you have a disease like this. Now, a few words on the therapy itself. So as we think about therapy, and again, and it's certainly welcome to share these with all of you by email, because I know the fonts are small. But physicians have very much like a cookbook of what are the national guidelines. And you can think they're, your standard hematologist or hematologist oncologist is caring for many different diseases. And the therapies for these diseases are changing rapidly. There are dozens of new therapies that are approved a year. And whether they're treating lymphoma, myeloma, polycythemia vera, on and on, they keep track of these things with these national guidelines. And again, we evolve in terms of, how do these sort of tools help to support physician decision support. So that, again, they're not relying on, well, back when I was in medical school in 1995, we did this. Well, a lot's happened since 1995. So with this, to give you a frame, we start with ET, and people who are higher risk, age of greater than 60 or thrombosis. We then try to manage cardiovascular risk factors, and we consider medicines, either hydroxyurea or a long-acting interferon, as our preferred frontline treatment, and then monitor to see, do they achieve what we wanted to achieve? Now, we have several gaps. Who needs treatment? In the ideal world, we would treat everyone. Whenever you see that we're not treating everyone, it's more of a limitation of the medicines that we have. If we have a medicine that's a cure, everyone gets treated. Nobody says, boy, who should we treat who has strep throat? We treat everyone because we have antibiotics that overall are safe and very effective against eradicating strep throat. That's clearly where we hope to arrive. The second goal is, do we manage cardiovascular risk factors well? Most of the time, that's probably not the case. So you can think for the general public, we have goals in terms of blood pressure, cholesterol, etc., that we've learned over time are helpful. They are more helpful when you have an MPN. The levels are not lower, so you don't have to have a lower cholesterol than is recommended for someone of your age, but it's probably even more important than for an individual who does not have an MPN. You're going to think an MPN is like an additional risk factor for vascular events. It's like if you don't have a family history of heart disease, it's like the equivalent of that kind of brought in, particularly if it is not controlled. A well-controlled MPN probably makes that risk closer to the general public. Third, we need more treatments. With each of these diseases, a theme you clearly get is the number of approved therapies that we have is still very modest and very few. With ET, it's 3 drugs. And of them, the only drug that actually has an FDA approval for ET is anagrelide, which is probably our non-preferred drug. Hydroxyurea actually has FDA approvals in other conditions. It's considered standard in ET, but that's different than somebody going through the process of getting it formally registered. And likewise, long interferons, we have more than enough data to have it approved, but there's never really been a champion who's really gone to the FDA and really gone through that process to get that approved. And gap 4, which is probably one of our most important, is why do people progress? One key thing is that for the majority of MPN patients, if the disease did not progress from the time of diagnosis, the disease would not become life-threatening. So the issue of progression is the villain. We don't know why that occurs. We are hopeful that some medicines may have some impact. Interferons may have some impact. JAK inhibitors may have some impact. But we still do not know why that occurs. And once we do, then we will be able to develop therapies to target and inhibit progression. Or we'll be able to monitor and say, boy, we have you on interferon with the hopes of trying to delay the risk of progression. Do we have you on enough? PV. PV, again, similar, but with one important addition, the control of the number of red blood cells. The hematocrit is a percent of blood by volume that are red blood cells. So our goal is a strict under 45%, and in some individuals a little bit lower, when a tube of blood is spun down, because we know levels above that increase the risk of thrombosis. Other than that, it is very, very similar to ET. Who do we treat? How do we manage cardiovascular risk? We need more therapies. And why do people progress? Additionally, the JAK inhibitor ruxolitinib is approved in polycythemia vera. It's probably also helpful in ET, but it does not have an approval in that state, and particularly helpful for enlarged spleen or symptoms. Indeed, I've discussed this issue of progression many times, and as you hear the talks on therapies in development, this is really one of the key targets. We know that when people progress, the blood counts tend to be lower, there tend to be additional mutations, the bone marrow starts to change, the spleen becomes larger, and the symptoms are different. Myelofibrosis. Myelofibrosis, we now have 4 approved drugs, and Andrew Kuykendall, wonderful friend, a great speaker, will go in depth into the JAK inhibitors in his discussion, as well as Naveen will be sharing with you some thoughts around particularly combinations of JAK inhibitors and new therapies. Myelofibrosis is the least common of the MPNs, but the most severe. So to give you a rough idea, there's roughly 300,000 Americans or so with ET or PV, and about 20 to 30,000 with myelofibrosis, to give you a sense of the numbers. Now, in myelofibrosis, again, we have similar questions, but a different set of issues. First, who needs treatment and when? Second, the issue of bone marrow transplant becomes important. So next, my good friend and colleague Mike Grunwald from our cancer center in Charlotte will be speaking on this issue of transplant. Transplant can cure myelofibrosis, but it's a complicated therapy, and it comes with some real risk. And what Mike and his colleagues do so well is try to balance, well, does the benefit outweigh the risk for this individual? And then how do we do everything we can to increase the safety and improve the outcomes with transplantation? Third, we have 4 JAK inhibitors, and they're great, but they overlap in terms of their effectiveness, and we are trying to move them to the next level of therapy. And then finally, still, patients can progress. Why do they progress, and how do we help prevent that? And the 5th gap, how do we really have our therapies have a deeper impact? Our goal clearly is to cure the disease. Other than transplantation, we are not there yet. Now we have 4 therapies, and again, I won't go into them in depth because Andrew will be doing this later, but ruxolitinib, fedratinib, pacritinib, and momelotinib. A mouthful. They all sound alike, and that's for a reason. They're all biologically similar. They all work to turn off that on-off switch. They all have benefits in terms of spleen and symptoms, and they have some important differences in terms of side effects, impacts on blood counts, and others. I'm grateful that we have this range of options. They've made a big impact. People are living longer with myelofibrosis clearly than when I started my career, no question. And people are living better, but we still have important ways to go. So how do we put it all together? First, we have to think about the entire individual. Not just your molecular profile and not just your blood counts, but everything that makes you as an individual is critically important in this shared planning process. Second, you could think that the journey from illness to wellness is more than just eradication of disease. And I think that's something we've learned over time, that we have medicines, we have surgery, we have transplant, we have new immunotherapies, on and on. But the journey from illness to wellness is more than just the eradication of disease. It is everything else that makes life worth living. It is how we feel. It is our family. It is the ability to do the activities that we want to do. How do we change the negative impact of these diseases upon individuals? And I share this because sometimes even if we can't eradicate the disease, we can still make continued strides toward wellness, even while keeping a disease in check. So with that, I very much would like to thank the MPN community. This is an incredibly collaborative community, both here in the US as well as internationally. The only competition is the diseases that we are battling against. And the impact that we've done has really been a partnership between patients, physicians groups, philanthropic organizations, wonderful groups such as MPN Advocacy and Education International, all working together to try to make a difference, whether it's new therapies, educational events, online webinars, teamwork, etc. So I'll take a question or two. This is kind of my typical Tuesday morning here in the Carolinas, here in the beautiful Blowing Rock. What you miss is I took this photo right after somebody proposed to somebody on this very spot. So this was very much of an anticlimactic photo of the old guy on the rock after the entire bridal party had just been there on this amazing morning. The old guy. But I'll take a question or two before Mike walks us through transplantation.
Any questions? Yes, sir. Here you go. Do you mind using this?
MPN. Oh, I'm sorry.
There you go.
You mentioned that MPN will always progress to the MF, the myelofibrosis. Is that correct?
No. So I should have clarified that further. ET and PV can progress to myelofibrosis, but it does not do so always. Roughly 10 to 20% over the course of the disease. Individuals that have the disease for a very long time because they're diagnosed at a younger age may have a greater likelihood. People who are diagnosed later in life, it's probably closer to 10% based on their age and other factors. So it clearly can progress, but it is not a certainty for most individuals.
And you also mentioned that, I think, that you can cure myelofibrosis. Is that correct?
We can cure myelofibrosis if someone has a successful stem cell transplant.
Oh.
I got one more. Ann, I got a question. Go ahead.
You mentioned that JAK2 positive. If you're JAK2 negative, do these treatments work effectively in myelofibrosis?
Yes. So we believe that everyone that has the diseases, there still is an overactivation of the JAK-STAT pathway. So that is the JAK2 V617F, CALR, or MPL, but we have found that the JAK-STAT pathway is overly active in individuals that lack all three of those. Some have used the term triple negative or lack all three of those, but the pathway is still active, and the medicines are inhibitors of the pathway. So in terms of the effectiveness, we have found them to be relatively equivalent. We'll go ahead and take one more, and we're going to
Yeah,
have
any other
lots of time for
questions?
questions kind of throughout the day.
Yes.
For people diagnosed with both ET and MF, but ET is favored, how is MF? Trying to think of how to phrase it. How is MF? I can't think of the word.
Let me explain, I think where you're going to. So ET and MF are a continuum of one another. So individuals really have either one or the other, but sometimes people can be in a bit of a transition between both. There are individuals in our field that have used the term early myelofibrosis, meaning they have some features of ET and some features of myelofibrosis. So with MPNs, people almost never have two diseases. Let's say people do not have both ET and PV. ET and PV are almost a continuum of one another, particularly those that have the JAK2 mutation. There's a continuum between ET and PV for those that have the JAK2 mutation. There's a bit of a continuum between ET and myelofibrosis. But I know it can be very confusing because people can say, well, how do I have two of these diseases? With rare exceptions, people really only have one disease, and sometimes it's our clumsiness in terms of describing where on what's a biological spectrum people typically live. If people say that you have ET and MF, it probably is more ET than MF historically. Well, let's transition. One more or one more?
Hi, Dr. Mesa. I have a question regarding MF patient, right, who's taking Jakafi. So usually how long can it be effective? I know people talk about 3 years, so I was wondering how long.
There are individuals that have been on ruxolitinib or Jakafi, which is the first of the JAK inhibitors, since we first started using the drug in clinical trials in 2007. So we have not found that there is a time limit. The average has been roughly 3 to 4 years, but there have been individuals that have been on for well over 10 years over time. We know that it can be very helpful for a subset of individuals for a long period of time.